gracias, Roberto. Buenos días. I was supposed to speak in Spanish, but they asked me to speak in English because I prefer to speak in Portuguese, but that's not a big problem. So no marcha, no cambia. Tiene que no cambia, se cambia. No cambia. Sí, voy a empezar I will start talking a little bit about it. The previous presentation from Dr. Percy showed you the way to do cleft lip and palate. And today, I'll try to show you what happens in my career after 30 years doing craniofacial and some cleft lip and palate surgery. And I started doing different kind of techniques. Different kind of techniques, but now I have a different approach. This is my disclosure. And it's very, very interesting because we still have a big challenger. A big challenger doing cleft lip and palate. And you have here two different techniques. One is Spina technique, a very old one that we used to start doing this. And the patient below has a millar. So it means that we have 2 points that's very important to see during this learning curve of cleft lip and palate repair. So you have a technique and technician, but also you have to follow your patients, do some audit, and try to make this as a good learning curve for you. So here is what happened with me. I started doing Spina when I was resident, and then we charged to millar, and we did some modification in millar, and we end up doing Fisher technique. So, but if you look at these principles, we keep doing Fisher technique by doing the same thing. Release the medial upper lip structure, septal cartilage repositioning. So it means that some of these steps, like medial elongation, oral mucosa and skin, and for this we could achieve and do and restore the muscular continuity. So there's also, we add to this and we add reposition of the nasal cartilage and close the nasal floor with the vomer flap. So, and one of the points that's it's much more important for us is no tension on the lip scar. So this is briefly showing some of these steps, releasing medial side of the cleft lip and palate. And you can see that we go through the nasal septum dissection and to reposition the columella. And then you can see here that's in the lateral element, and it is the same. You can take a look at the muscular dissection, and also we extend the incision through the nasal floor. And as you can look at this kind of dissection, and this even changing the way we now do Fisher repair. We have this is some of these results that you can put for even incomplete cleft lip and palate, and also for complete cleft like this one. You have well, you have also good results. It's not working. You can pass the slides there. Can ask you? Well, so you can achieve very good results in large clefts or even not in large clefts. But Oh, shit. Can you change this or just, can you move the slides? So, what I'm trying to say is that it's not working. I have a 10 minutes presentation, and if it's not working, I cannot do anything. I'm pressing here. Yeah. Can you change so, and then for this kind of techniques, we have like the same principles. And what changes is when you look at the long-term follow-up of these patients, that's the reason for changements. And one of the things that is very important for us when you do markings, you follow the principles. And the principles are not just in the way you mark here. Can you move forward for me? Es que se puede pasar los diapositivos para más para frente. Más para frente, más para frente. These are some example that, can you pass? And then why do I change the technique? That's is a very interesting story. 2003, we met Fischer in Brazil. He was doing the Fischer technique. At that time, I decided not to change. Then we have here Renato that started doing this technique in 2004 and keep asking, oh, why you don't change, why you don't change, and then move, please. And then we decided to move, and we had a learning curve, but there was some points that I think that was a very, very good point to learn about the Fischer technique. The scars in the static lines, and it's a very interesting rotation of the alar base. And also, there was a very good teaching tool, because as you could see in the morning, Percy could teach you to do, and most of you could do the lip repair with the fish technique, even though you have some problem and difficulties to understand very well the menus of these steps. But now we do some kind of Fischer, but we still keep doing some of the same principles that I have shown you in the first slides. So next slide, please. And then is the way you, thank you. The way you can see here the Fischer technique. And one of the points that's very important is the incision, the scar, should stay on the filtral crease. Otherwise, you will not have the good thing from this technique. So that's the straight line scar without any kind of retraction or any kind of shortening of the medial element. So I'll move forward with this video because you have already seen this, and this was very well demonstrated by, very well demonstrated. Can you move forward to the patients? Yeah. So, and then there's some of these cases that you can see my experience, and these are patients that I started doing this technique 2013, 2014. At the beginning, we started just to make some evaluation. That was, I said to Renato, we have two groups of patients. One of them we was doing Fischer technique, and the other one we keep doing our technique. And we were so surprised when you look at this long-term follow-up. Long-term is 10 years follow-up. And you see the white row and also the scars. And some of these patients that we touched the nose, and here you can see, we realized that, well, maybe we should work more on the nose. But at the end, we realized that it's not just the position of the alar base, but also you have all other problems that you have to evaluate. But one of the very interesting things is when you have like this case, you have a short lateral element of the cleft lip, and then you can have a very interesting final result, mainly in the size of the cleft side. And you don't have any problem to elongate the medial element. You can do this whatever you want, like you saw in the morning, you have some checky points that can assure that your technique is elongating very well your lip. So I have the first checkpoint is when I do the medial element, I measure the side of the small triangle because I cut it and see if my lateral triangle is okay. And then I can move for the second checking point. The element is when I do the cutting on the lateral elements. And then for this reason, you can have like good results, good position of the nose. And then we observe that there is no scar in the columella. So that's a very interesting because we have like these patients that we have some follow-ups, and it is very interesting because we took not just this the best cases to show you, but we made some consecutive cases. So we take these patients from 2017 and we follow these patients in a row. These are patients that we did in a sequence, and you can see some variations of the results, mostly in the nasal position, but not in the lip repair. So then you can see some not good results for the nasal position. And then what we realize about this is points that are very important to achieve when you do lip repair. It's very important not to have tension in the primary lip repair. And we don't use any pre-surgical orthopedic treatment, but we still have some projects, some research going on. And one of them is in Bauru, trying to see if is there any difference from unilateral or bilateral. And I think that we could not have good results for this nasal stent or NEM or whatever. And even for this nasal modulators, we don't use any of this. And for some of these patients, maybe it could be interesting because you have some consecutive cases that the nose is not always the same. But one very important point that Fischer just mentioned very well is the reposition of nasal septal the nasal septal cartilage. And also, almost the same as before, it's very important to reestablish the muscular continuity. And one new thing that we add for all this is we use the Vollmer flap for the old techniques and the new one technique. And we have all the nasal floor very well closed. And then this is something that we really think that helps a lot when you do alveolar bone grafting. So in the final position of these consecutive cases and all these cases, we have some analysis on the final results and in which cases we have a good nose position, bad nose position, and we realize that the size of the cleft most of the time have some influence in this final result. But also, we notice that the quality of the nasal cartilage, they could also make some difference in the final position of the nose. So sorry about the slides, but that's my experience along this last years. Thank you very much for your attention.